Are you a runner battling knee pain? You're not alone. In this episode, we'll explore the common causes of knee pain, effective prevention strategies, and essential rehab tips from expert physical therapist Dr. James Babana. Learn how to understand your body better and get back to running. Don't let knee pain slow you down. Tune in and learn how to keep moving and improve your performance. I'm Dr. Tammy Penhollow, knee and spine pain expert, and my guest today is Dr. James Babana, PT DPT. Welcome, James. Give everybody a little bit of an intro to you, and then we're going to dive right into this topic because I've got a lot of people sending me information and questions specific to running as they're getting back into running, or those who are actually at performance and they've had an injury and they want to rehab.
That sounds great. Well, I appreciate the introduction. And my name is Dr. James Babana. I'm a physical therapist, and my practice called Push Through Performance is located up in North Scottsdale. And what we do over at Push Through Performance is we focus on helping active adults, primarily people that are recreational athletes or people that are professionals, not only get out of pain, but also get back to their sport, get back to their activities, things that they want to do, and optimize their performance as much as possible. So we're not just about addressing pain, we're more so about helping people get back to the movement and get back to the things that they love most.
I love that. That's what it's really about, right? I mean, there's going to always be something that happens. You might get a tweak. You might have run a little bit too hard that morning. You've got some tightness in the hamstrings or whatever. So I never try to promise person a pain-free life in general, but how do you optimize? How do you maybe do some prevention? Can we go back to the very basics and just start with if a person does have pain with running, because we do want to go there, what are some of the most likely causes? And you can talk about structure, you can talk about function, combine that.
Sure. Yeah. So let's break it down a little bit more simply, right? So we want to understand, where is the knee pain coming from? Knee pain could be coming from the knee. It could be coming from elsewhere as well. So sometimes it could be coming from the back, from the hip. So we really first and foremost want to understand, where is the source of the knee pain coming from? Primarily, you're going to have knee pain that's coming from the knee. And a lot of times this comes from, a change in activity. Maybe, you were getting off work and you were sitting for a long time and you've been stressed that week and you went out for a run and you decided that you wanted to push it a little bit harder because you've been a little bit more sedentary that week. And as a result of increasing that intensity or running a little bit further than maybe you were used to, you might have experienced a little flare up in your knee pain. So, or whether it's new onset or something that you've had previously. So what you want to understand is, where do you localize it to? Because you could have pain around the kneecap. You could have pain inside the knee, like for example, the meniscus, patellar tendon. Yep. So right where the quadriceps muscle, that big muscle, tapers down and courses over the kneecap. You could have injuries to the collateral ligaments on the sides of the knee, inside the knee. It all depends on what was the mechanism of the injury, how did it happen, and going from there. Really, does that help?
Absolutely.
To a good direction.
Absolutely. Then we can talk about outside of the knee pain, inside of the knee pain, internal to or at the kneecap. So there are lots of common causes. What are the most common runner's knee causes?
So I would say the most common causes are a sudden change in volume. Like, for example, they started to increase their running mileage, maybe 3, 4, 5 miles a week extra. And maybe they weren't quite used to it. They might have been dealing with a slightly nagging injury prior to that, but that simple increase in volume might have just pushed their tissues over the edge and made them more sensitized. So those are probably the most common causes. But other than that, if they're incorporating any speed or tempo work, something that they weren't quite prepared for, especially as they're in, marathon, half marathon training, oftentimes it's like a 12-week block that people will start to prepare for and gradually ramp up their intensity. So if it's something that they weren't quite prepared for, that's usually the trigger for it.
Okay. So it's more of a change in either intensity or the length of the training. You can't just all of a sudden get up off the couch and all of a sudden start to run 3 to 5 miles a day for 5 days a week, right?
But basically, there's a lot of really good apps out there and programs that are like Couch to 5K and all that. And those are good because a lot of times it starts off with running, walking combinations. And from our more where I'm seeing people getting injured the most, these are active adults. They are, able-bodied, they're strong. They don't really have too much of an injury history. So a lot of times once we start to get a little bit older, creeping into our 30s and 40s, we're not quite in our 20s anymore, where we're very injury resistant. And especially as we start to sit into more sedentary jobs or we're traveling more, our tendons and our muscles can become a little deconditioned. And as a result, they don't have that same spring and that same resistance to injury. So a lot of times we'll push the intensity. So we'll say, it should be fine. I've done this before. I used to run last year, 3 to 5 miles, no problem. And you run it and you realize that your body isn't quite at the same place that it was a year ago or even 6 months ago. So when you take breaks or when you start to increase beyond your current abilities, you have to realize that your body takes a while to adapt. So our biology takes a while and repeated inputs of that activity in order to change.
I love that you're breaking it down like that. When you see a person who started in a running program or they've been off from a injury and they're coming back, do you find that IT band is one of the biggest culprits? That I tend to see a lot of that if a person does have kind of those tight hip muscles or they don't have maybe the correct shoes, and maybe that can lead into, they're using the shoes from 2 years ago. Can that lead into a further discussion on this?
Yeah, that's a good question. So if I were to rank it, I'd say in my practice, IT band syndrome, where it's kind of like tender on the outside of the knee is definitely one of them. I wouldn't say it's my top, seeing diagnosis. I would say mine is more so a more general version where it's like patellofemoral pain syndrome. And that's just more of a generalized pain in and around the knee. So you'll typically see that around the kneecap. Aside from that, you'll also see like this kind of patellar tendonitis or tendinopathy. So that is where the tendon connects from the kneecap down to the shin bone. So those areas, I would say between IT band syndrome, generalized patellofemoral pain syndrome, and the patellar tendinopathy, those are usually the most common that I see.
Sure. No, I've done some videos talking about PFPS, patellofemoral pain syndrome, as being known as runner's knee or jumper's knee. See it in the distance runners as well as those who do the jumping, such as basketball players. How does footwear play a role in running, and how you end up working with an athlete, an active adult, in, say, a program for them based on what they are wearing on their feet?
That's a really good question. So footwear can really make a big difference, primarily because there's so many different types of shoes and you have to consider multiple factors. So for example, let's just take the style of shoe, right? If you're running with a runner's shoe that typically tapers inward for your toes and you have a pretty wide toe box or your toes splay a little bit more, you're going to feel a little bit more crammed and it might affect the way that you're loading into your foot, which could affect the way that you generally transfer the weight upstream. So even something as simple as a toe box could affect you. So if we just dial it back to the most important kind of components, we think about, the cushion on the shoe. So for example, you'll see some shoes that are very minimalist and very thin. You'll see some shoes like, for example, the Hoka varieties, and I've even seen Sauconys and things like that, where they'll be extra foamy. It's like you're running up a cloud. You'll see a wide variety in between those two ranges and extremes. And generally what it comes down to is comfort. When you are adding more cushion to the shoe, it's going to reduce the amount of, we call it ground reaction force, that transfers upstream into the knee. So that could help you. Keep in mind that could affect some other stuff too, hip, low back, because just naturally working on a more unstable surface like a Hoka could add more muscular work and balance and coordination work to everything upstream. So just keep in mind, there's always a trade-off, right? But if you're working with a more minimal and flat footwear, especially if you're doing something like trail running, you need to realize that it's going to change the dynamics of your gait too. So the way that you strike, instead of doing a hard heel striking pattern, you'll more likely opt in for the mid strike, the midfoot, or the forefoot strike. And that could reduce some force upward to the knee. It could also open you up again. There's always a double edge, right? it could also open you up to some more foot and ankle vulnerabilities. So whatever you do, you have to realize that there's a trade-off. What I tell people is, what is your most comfortable shoe? What are you used to wearing? Because that's going to be the thing that they're already prepared to wear. We might just make some modifications. So if they're used to a really cushioned shoe, I would usually recommend, a shoe maybe that's slightly modified, still somewhat cushioned, but maybe not as much of a heel rise. So that way, it might change the dynamics of it. Does that answer that question?
Absolutely. It's so individualized. So then we can lead it back to, how do you actually evaluate that? Say you got a new physical therapy client, they're coming to you and they're like, I am now having pain with running. I used to run, I used to do 10Ks, 5Ks, all the way up to marathon. I don't want to do marathons anymore, but I do want to be able to go out and do these, 5Ks and 10Ks for charity and with my kids. I'm having some issues. Do you have them bring the shoes in? Do you do a gait analysis? And how can you do this different than, say, another PT down the road?
Good question. So the first thing that I'll do with my evaluations, and I'll put them on a video motion analysis. So I'll have them on a treadmill, which isn't the best. I'll be very forthright about that, because the way you run on a treadmill is different than the way you run outside over ground. They've done research studies on it. The belt-fed system is just very different. The closest thing you can come to it is one of those beltless systems where, like, you have the aerosol treadmill that has I can't remember, the slats that just roll with your own force. So that's the closest that you can come to it. But what we do is we start off with a video motion analysis so that we can understand the gait cycle of the person. As you may understand, everybody's gait is a little bit different, and they come with prior injuries usually, which could affect how their joints are moving. So for example, sometimes with people who have knee pain, they'll show me some restrictions at the foot and ankle. And those restrictions at the foot and ankle could also impact the way that the knee and the hip move. So I'll give you one example. Let's say you have knee pain. One of the things that I see with knee pain is that they will have, in some cases, a very hard forefoot strike, and it could increase that force at the front of the knee. Again, where is the knee pain? It also is very dependent, but just to give you this very specific example, if they're a forefoot striker and their force is coming down on the ground like this, it's causing their knee to push forward and adding more resistance toward the front of the chain. So that naturally over time can produce stress, especially if we're talking about, running volume. If you massively increase your running volume in preparation for a race, or you've started to change your training intensity. The other thing is that if you have any sort of resistance, for example, let's say your ankle is stiff and it doesn't bend very well into the stride, well, then that naturally could add a little bit more pressure to the front of the knee, because now your knee and your calf are adding resistance upstream to the knee. So it's like, how do I simplify it? Well, maybe I don't go too deep into that, but I'll just say it like this. With ankle stiffness and the difficulty in bending the ankle upward toward the shin, as you're going through your running stride, it could add more force onto the knee. And similarly, it could also impact the hip. So this is where we see some of the chain, we call it the kinetic chain, and how upstream can influence downstream and downstream can influence upstream. So we really have to take the whole picture into account.
Absolutely. I know that you've talked about more anterior front of knee pain that can be from more of that forefoot strike. Can you also talk a little bit about supination and pronation, how we can potentially see more on the lateral medial aspects of the knee? And that's why a lot of people are supinators or pronators, and they have special shoes for that.
Yeah, great point. So what I'll often see is that I see more people who overpronate rather than overly supinate and have high arches. There's just a small fraction of runners that I'll see that are typically like that. But for the overpronators, what I see is typically the arch will collapse as they're starting to put weight on that foot. So you imagine as you're putting weight from the heel through the midfoot and your leg is gradually underneath you, what happens is your arch will collapse and your knee will fall more inward. That's very common, and a lot of times that can lead to these plant and twist type of strains. we call them more dynamic valgus type injuries. So potentially the patellar tendon, we're thinking meniscus over time, we're thinking a medial cruciate ligament, or MCL as we like to call it for short. And those are some of the more common. And then sometimes we'll see, just naturally some IT band, discomfort as well with that. So with the people who are supinating, a lot of times what we'll see is that they prefer a more supported arch. So they'll have like some sort of arch support there just to support it so that it's not doing so much work. Now, with them specifically, I don't often see as many knee injuries. It's more often the foot, ankle, and calf injuries that I'm seeing with them. So that's just mostly what I'm seeing in terms of trend.
That's perfect. Thank you for clarifying that. There are obviously some limitations to the treadmill evaluation. Do you at some point take it off the treadmill and you may go on a training session with them where you're on their favorite trail, or you're on, if they're running on grass or they're on the road, that you're reevaluating if there's some kind of recalcitrant injury or recalcitrant pain? Or how do you do that in your practice?
I haven't done that yet. We do have a small running area outside my office that is, without cars. It does have some turns involved in it. It's about, 50 to 75 feet of a training loop, one direction. So what I do if I really want to see somebody's running gait is I'll take them out there and then just try to understand it from that aspect. So it's not feasible for me to get out to the track unless if I'm doing multiple patients at the same time and just analyzing people or training. But maybe that's another idea for me to consider.
Well, I'm not trying to add things to your plate, just wondering how you are working with these athletes as they're moving through. And I know that you're able in your practice to do very individualized training things. You don't have a typical practice. Kind of show us what that's about in a synopsis. And then people are going to understand why I'm saying that you can do one-to-ones the way you do.
Yeah, right. Yeah, so the way I structure my sessions, right, I'm very much focused on performance. So in the initial stages of care, it's not so much initially focused on performance as it is symptom management, because you have to realize that there's a spectrum, right? So in the beginning, I'm always going to be focusing a lot more on symptoms rather than performance. Gradually, as we're starting to work our way out of that, we're focusing much more on performance and less on the initial symptoms because they've calmed down by that. So things that we're doing in order to help them are making sure that we're having a good conversation about factors, running factors, right? So talking about what's their current mileage, what is their footwear like, what are their sleep strategies, what are their nutrition and hydration strategies, because all those play a factor. Now, specifically for running, I want to see what's their mileage, how are they planning on increasing from week to week, and are they incorporating things like tempo runs, speed runs, because that could directly influence how their symptoms are responding, right? I have some people that are very, very active, and sometimes that's to their detriment. It's not allowing them to heal. So they'll be doing weightlifting, they'll be doing running, they'll be doing some other sport, and in between, they'll be incorporating my rehab and fitness exercises. So it's just a lot for the body. So in order for me to help the athlete, I have to understand their whole cycle. That also may incorporate, working with running coaches or working with weight training, personal training coaches, or if they're specifically, like, for example, I have a baseball athlete right now who I am kind of indirectly working with the baseball coaches on programming. So all these factors come into play. In the beginning, what I'm focusing a lot more on is soft tissue work, improving the joint flexibility and mobility, improving muscle activation so that we can gradually improve some of the accessory muscles that might be weak, and even putting load and strain through the muscles and tendons that might be strained, right? Or ligaments if they're sprained. So that way we can gradually progress more toward performance.
That's perfect. Yeah, I agree with working with everybody else, because a lot of people come to you and they're already working with somebody. And so the fact that you can play well with others and you're not giving information that is kind of in direct conflict with what else they're hearing, because how confusing would that be? I love that you're working with everybody. And things that you focus on are that sleep plays a role, nutrition plays a role. All these things are very important. Hydration plays a role. So I'm so glad that you are probably reinforcing. I don't think it's probably the first time that somebody's going to hear it, that they need to get enough sleep and eat well and hydrate well, but the fact that you're reinforcing that can only help.
Yeah, it's such an important conversation to have, right? I tell people I'm an orthopedic therapist, that's my major. I'm a sports therapist, that's my minor, right? But what I most like to focus on is the basics. A lot of times, if we can just get the basics right, it can really help our bodies to improve and optimize healing. So, what we often take for granted is that our bodies are in charge of healing. What we do as therapists, what we do as healthcare providers in different spaces is just encourage healing. We reinforce it. And this is assuming you're not getting surgery, right? But like even in the sense of like orthobiologics, we're trying to encourage healing by setting up the environment in a different way and signaling and all that. With physical therapy, we're trying to promote healing by supporting areas of the body that are weak, by reducing tenderness of the body through soft tissue strategies. And that's how we do it, right? But if we can just get the basics right, so sleep is so important, restorative. If we're getting 7 to 9 hours of sleep, and not just 7 to 9 hours, but also regular, consistent 7 to 9 hours, reducing our screen time before bed so we can improve our sleep quality and depth, reducing caffeine stimulants prior to bed, things like that, nicotine, reducing alcoholic beverages prior to it. All these things, they're so helpful and beneficial. If you're not getting enough protein, how is your body going to be able to restore the muscle and restore the tendons to be able to, reinforce stronger? If you're not hydrating enough, how are you expecting yourself to perform and just be more cognitively aware of what your body's doing? Everything plays a role. So I try to get the basics and the fundamentals as close to perfect as possible so that it's not me doing the work, it's their body doing the work.
Absolutely. You're optimizing them, putting them in that status. And the answer is you can't get the performance you want without the correct sleep or enough protein. You're in a catabolic or breakdown state rather than anabolic or rebuilding and rejuvenating state. You can't without hydration, same. So that's the real answer is you can't. Can you break it down a little bit on the importance of warm-ups and cool downs? Because when you are maybe an athlete in college or high school, or even as a recreational person where you know that you don't just get up, put your shoes on and go sprinting out the door, can you kind of give a good idea about the importance of and why? Why do we stretch a warm muscle versus a cold muscle? Those kind of things.
Yeah, it's such a good topic where we can discuss also too what it looks like. What do warm-ups and cool downs look like when you're in the injury phase and managing a lot more of the symptoms versus when you're in the performance phase of things, right?
Perfect.
So what we can do is we can address and tailor the program based off of where they are in their phase of injury. So in the earlier phases, the warm-ups most often look like more soft tissue strategies, more joint mobilization strategies, more muscle activation strategies, not just for the area that's injured, but also surrounding. So the areas that are at a deficit, maybe it's the hip abductors because they're not supporting the knee well, contributing to more of that valgus, medial or internal type of injury to the knee. Or maybe it's like working the calf so that we can get a good muscle pump and warm up through those tissues so that the knee can be well supported when we're planting and stepping through. Those types of things are really important for the warm up when you're in injury phase. So I might advise foam rolling, massage gun, lacrosse ball for maybe 3 to 5 minutes, and then incorporate some sort of muscle activation prior to that or after that for another 5 to 10 minutes. And the reason why is because as we're warming up, we're literally warming up the internal environment around our tissues. It improves tissue pliability. It improves your extensibility. It reduces your risk for these types of strain injuries. So that way you can, optimize even the initial part of your performance. Once you get into the main block of your exercise, that will help to improve even the initial part. So that's where I go with that. Now, as they're transitioning out of that injury phase and more into performance, I'll often recommend, tapering away from a lot of the passive modalities. So massage gun, lacrosse ball, foam roll, I'll advocate for less of that because typically you don't need to spend as much time on it. It's still helpful. So for example, a lot of times people will bring their Theragun with them and, just and use it prior to it. And that's great. It helps take the edge off. It prepares the muscles, nerves, etc. I'll advocate much more dynamic warm-ups. So these are more generalized warm-ups, along with maybe some specific warm-ups that were related to their injury. So instead of just doing, hip hikes or heel raises or things like that, we might be incorporating more skips, more hops, more single leg plyometric work prior to it, because now they're out of the injury phase and more into, the performance. So in terms of cool downs, that doesn't change very much. All we're focusing on with cool downs is some activity to bring the heart rate down, walking or slow jogging, depending on, what pace that we're running at. Just something to gradually, stepwise decrease that heart rate. And since the body is warm, that's often where I'll encourage people to focus on joint mobilization and static stretching techniques, because that's where our body is more receptive to that because it's so warmed up.
Completely agree. I don't know how many people I see on, say, the pickleball court who, they just walked from their car and all of a sudden they're doing very static stretching. They're reaching for those toes and they're completely pulling their heel into their butt and doing a quad stretch, and they've not warmed up at all. So I'm not imagining they can get that full joint mobilization or stretch to that. So thank you so much for kind of breaking that down.
And if I can also add one more thing. So I like to share this with people because it kind of humanizes the physical therapist. So I have sustained my own injuries, right? I know based off of research, based off of clinical evidence, what I've seen with other patients' experience, but also I'm a human being too, right? So I've experienced meniscal injuries. I've experienced also my own calf strain. So sometime last August in 2023, I suffered from like a partial rupture of my gastroc. So that's the most surface layer of the calf. And I was playing pickleball. Now, I got there. I was a good boy. I did my warm-ups and they were a little bit more dynamic than static, how we were talking about, right? I practiced hopping, jumping, I practiced heel raises, I warmed up my hips. So I thought I was prepared and good to go. Now, 5 minutes into the game, as soon as I step off to return a serve, I felt a pop. So even though you may warm up, even though you may do your best to prepare, you could still suffer these injuries. And it's okay. I mean, we're not perfect. We're not invincible. And just because you do a warm-up doesn't mean you're going to be able to prevent an injury, but maybe you can reduce the risk of it. So what I would encourage you to do is at least take the time to do the warm-up, because it can reduce the risk of your injury.
Absolutely. And we're all about that, right? Isn't the goal to stay as active as we can and to increase our health span? And if you're injured, then you feel a little dejected. We've done an entire podcast on how to deal with the psychological aspects of that with a sports psychiatrist. So there are so many different things you can do from a physical therapist standpoint. Say you have sustained an injury, you just strained your gastroc. How are you likely to then see a patient? Ideally, do I call you that next day and say, this is what happened. I'd like to get a hold of this earlier rather than later. I know that I can do the rest. I stretch, whatever, if you were still in the RICE program, or are you going to set me straight and say, look, let's look at it a little bit different?
So the main thing I try to express to people is when you're experiencing that acute injury, you can definitely come to see me. If it's more urgent, like you think you fractured something, go to urgent care, go to the emergency department, because you want to make sure that you can get some imaging. That way, if you need to brace something, put it in a protective boot, cast, that's really important. So if it's a more major injury where you're suspecting a fracture, definitely go see urgent care physician, because they can triage a little differently and treat you appropriately for those types of injuries. Now, if it's more of a strain, like I felt a pop, I felt a rip, I felt, a twinge, those are the types of things that I can also look at and assess and treat. So what to keep in mind for the very beginning, like for example, when I strained my calf, you couldn't tell what was going on. It was so swollen. And that's normal. That happens. When you experience some type of an acute injury, you get swelling, you get pain, you get generalized tenderness, you get bruising. So oftentimes we can suspect what happened and then treat accordingly. So if you want to make sure that, everything is okay, either go into the urgent care or come in to see me and we can triage it and give you an idea. If you think it's a more minor injury and you want to wait for some of the swelling to come down, then we can do that and also see you 3 to 5 days after too. So I always like to err on the side of caution though, and that's why I tell people about urgent care and emergency.
Absolutely. No, we've got to look at the big picture first and rule out that there's nothing that is surgical or emergent. But if it's not, then how we can then move on into a rehabilitation phase. And I think you've explained nicely that there's some changes in what even you're doing with somebody in the acute. Is there an intermediate before you then jump back into performance? So I kind of know what you do acutely, but then can you show the progression of an athlete?
Yeah, so just to backtrack a little bit, so with an acute injury, a lot of times I'll recommend things that are to deload or to reduce the load and strain. So I'll tell people, hey, peel back this activity. Instead of running, let's switch to walking right now. If you don't have your normal gait cycle, let's just try to restore and normalize our walking, right? If you need compression garments, add compression garments because it helps to keep some of the excess fluid out of the area. Make sure when you're sitting for a long part of the day, elevate it, keep that ankle moving, keep the knee moving. We've gotten away from pure Rice and Price models where it's like rest or protection, rest, ice, compression, elevation. And we've gone toward more of this peace and love model. That's the acronym. So they've gone into more of that hippie direction, peace and love. So, but if I can summarize it for you, it's mostly reduce the amount of NSAIDs and, painkillers that you're taking because that could influence the healing process. Be as active as you can, realizing that we want more active recovery versus passive rest. So there's a difference. And that's exactly what I was trying to explain about the walking cycle. Get the basics first, restore your walking, keep your body in motion as much as possible because it'll help to reduce swelling, pain, and keep your muscles active and resisting atrophy. So what I do after that is more so at building muscle. We're still incorporating some soft tissue techniques to reduce swelling because usually if it's a significant injury, even at 2 to 4 weeks, you're still experiencing some swelling. So doing things to help reduce the swelling, maybe applying some kinesio tape, and then even incorporating, active strategies for, continuing those muscle pumping kind of behaviors. But that's really where I'm incorporating a lot more direct training to that area. Whereas in the beginning, I was protecting it and not doing as much directly, allowing the body to heal.
Right. I love that. Peace and love rather than Rice and Price. So you've heard it here. That's fantastic. That's fantastic.
Yeah. And there's general guidelines. If you look online, if you type in peace and love injury guidance, you should find it.
Perfect. Thank you for that. Thank you.
Yeah.
So I'm thinking we talked about most common kind of injuries, more of an overuse, more of a maybe accelerating your miles or accelerating the number of days a week that you're running too fast without a nice gradual ramp up. On the prevention, we can't 100% prevent, but we can reduce risk. So we've talked a little bit about warm ups and cool downs and having the right shoes and, of course, the sleep, the hydration, and the eating. You've given a lot of rehab tips. I appreciate that. What have we missed? What are some things that you really think that we need to hit hard on to let people know that when you are in a running program, whether as a beginner or as an elite athlete, these are kind of some golden pearls from a guy who's an expert in this. I mean, you do running workshops. You do big things on Facebook, Instagram, and your own channels. So kind of break it down. We've got an expert here. Spill the goods.
Yeah, sure. So what I'll tell people is you want to look at your body kind of like the way that you look at your car's dashboard. So if you see those warning lights pop up, typically what that means is you're having an area of soreness. You're having, one side of the body is more sore than the other. And it's been taking more than 2 to 4 weeks to go away. And it's affecting, more of your mindset and thinking, maybe I can't progress as far or as fast. So you want to pay attention to those warning signs because they can get worse, right? Now, with that said, if you're an athlete and you don't have pain, you are, probably the top like 5% of people or like 1%. If you're an athlete and you're pushing yourself, you're going to experience pain. So you have to know the difference between typical pain and discomfort that you can heal from, typically minor strains and sprains, somewhere within a week, 5 to 7 days, you should be feeling better and back to performance. But if you're not, then what I would say, especially if you're experiencing more bruising, swelling, more significant pain, get seen by a professional, because that's where we're going to go into our specific examinations, whether it's Dr. Penhollow, she's going to do her own examinations. I'm going to do my own examinations and try to understand more of your gait cycle, et cetera, et cetera. So what I tell people aside from that is that you want to make sure that, number one, soft tissue feels good. So incorporating good soft tissue strategies, foam rolling, lacrosse ball, massage gun, things like that. Incorporating good joint mobility strategies. So for example, you want to address a stiff ankle, and there's specific exercises, even on my YouTube page, that I've shared for mobilizing an ankle. And that's going to help to improve after you've done your soft tissue work. It's going to help to improve the way that your joint can move through the natural gait cycle. You want to address muscles that are weak, and don't neglect it. As runners, oftentimes we just want to run. We enjoy running, and that's why we do it. It helps us to feel good, clear our minds. It gives us that cathartic kind of dopamine hit, and it's great and all, but you need to make sure that you're doing your strength training on top of that. And just like I mentioned, the lifestyle factors, sleep, nutrition, hydration, etc., stress management, you want to make sure that you're getting your strength training in. Even if you do full body training for 2 to 3 times a week, that can be sufficient for you to resist bone stress injuries. It can be sufficient for you to reduce your risk of muscle and tendon strains, reduce your risk for ligament sprains with any sudden accident or anything that happens. So that's what I would recommend. 2 to 3 times a week of strength training, just to improve those factors and reduce your risk for injury.
Wonderful. Any other last words for this that we haven't otherwise touched on?
I really think that's it. If you're an athlete, if you're professional, make sure you're visiting with your physician, getting your annual physical, getting your blood work checked. Make sure that you're doing good things for your body in terms of managing the lifestyle factors, understanding, the amazing things that, like, even yourself, that what you can do, Dr. Penhollow, in terms of helping people in non-surgical and less invasive healing, so that what we do as physical therapists and coaches and performance trainers can improve people beyond, their traditional healing timeline. So, making sure that we touch base with all of our healthcare providers. If this is something that's important to you, if your body is something that you cherish, that you want to continue working well into your 70s and 80s and, God willing, 90s, then make sure you do the things that you need to do now so that you can reap the rewards of them later.
Absolutely. I couldn't have said it better. How do we find you? How do we work with you? Tell us kind of the main ways that people get in touch with you, and we'll obviously put them in the show notes. So if you don't have a pen and paper right now, we'll include that. But tell us how to work with you.
Yeah, so you can always visit my website. That's the easiest way, because we get notifications and we're able to reach out through our specific contact cards. So if you go to my website, pushthroughperformance.com, go to the contact page, you'll have different options there. Fill out your information, tell us what you need help with. If it's running related, if it's not running related, that's totally fine too. Even if it's not knee pain, we can still help, because we focus on everything related to running. Even if you're experiencing neck pain related to running, there's a lot of strategies that we can do to help people. So pushthroughperformance.com is one of them. If you wanted to email me directly, you have my email, info@pushthroughperformance.com, as well as Instagram and Facebook. So you have just @pushthroughperformance. So, or it'd be /pushthroughperformance for those. But I do have an Instagram account that you can also reach out to us directly, and we'll respond usually between 12 to 24 hours typically. So.
Oh, that's perfect. I thank you so much for sharing your knowledge and your expertise with us. I look forward to maybe joining you on one of your little running training sessions. And thank you so much for sharing with the audience today, Dr. James Babana of Push Through Performance.
Thank you so much, Dr. Penhollow.
Take care.
If you have knee pain and would like to learn more,
I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.